So starting, I think it'll, okay, there you go.
Perfect. Yeah. Hi, everybody. Thank you for your patience and thanks so much for joining today. I think this is our first CSB meeting of 2024. And so if you don't know me, I'm Shivani Mantha. I'm the Acting Assistant Commissioner for the Bureau of Alcohol and Drug Use after John left several months ago. And today, the meeting, I think we're pretty excited about this meeting. We just wanted to have a discussion about all of the recent federal policy changes related to medications for opioid use disorder and just talk about generally barriers to treatment and just generate ideas related to that. So looking forward to it, and I am going to, oh, sorry, could you do the next slide? I think I have a few, oh, never mind. I don't have updates until later. Okay, so that's it from me as of now, and then I'm gonna pass it off to my colleague Tina Saha to just kidding, everybody. I'm so sorry. I am not going to pass it off yet. I'm going to continue with this welcome just to give a few updates. The first is that we published a one-year report on the first year of OPC operations with our on-point colleagues in NEJM Catalyst. It came out, I think, about a month ago, if not like 6 weeks ago. We can distribute it after this call. This follows on points excellent first year report that they also distributed. This has kind of a bit more quantitative data on utilization of the OPC, utilization patterns, um, and things of that nature. Yes, Mike, I will definitely send you the full PDF. We'll distribute it to this whole group after this and try to do a better job about distribution of that because I know it's hard to access. I mean, I can't even access it when I click on it. So that came out. We're very excited about that. And then recently we also launched the fourth, and as of now, like the final public health vending machine in East New York. It's operated by Vocal in the Housing Works, in Housing Works' location in East New York. So we are very, very excited about that as well. And, maybe that's something that we can present about in the future about, just the utilization of that initiative now that we have 4, operational machines. Any questions on either of those before I actually hand it to Tina? All right, cool. Okay, so I'm going to hand it over to Tina Saha, who's our Senior Director for Substance Use Care, who will give a very brief introduction to some of the things that we want to talk about today. And then I think we're trying to reserve most of this space for discussion, as well as some time for updates and questions from all of you. Yeah, go ahead, Adrian.
Will you be sending out the one pager on 1 year of OPCs to everybody?
Yes.
Okay,
yes,
thanks.
we will send it. Definitely.
Great. Well, hi, welcome everyone. Good afternoon. Again, thanks, Shivani, for the introduction, and apologies in advance. My camera on Teams on my tablet today is just not behaving. I may try to finagle hopping on my phone, but was afraid to mess up audio before presenting. So apologies for not being able to come on camera. So again, I'm Tina Saw. My pronouns are she, her, hers. I'm the Senior Director of Substance Use Care in the Bureau of Alcohol, Drug Use Prevention, Care, and Treatment. So next slide, please, Winnie. Thanks. So yes, so we're going to talk a little bit about today about the various sort of policy updates, but just want to take a quick moment just to take a step back for a second and just acknowledge that while today we're focusing primarily on treatment, that the entire substance use continuum of care spans a number of these very critical areas, which in addition to treatment include prevention, harm reduction, and recovery. But today we are going to focus mainly on the treatment of opioid use disorders and how to address opportunities and gaps given recent policy changes. Next slide. Great. And so as many of you all are very familiar, when it comes to opioid use disorder, buprenorphine or bupe and methadone are considered the first line life-saving treatments for those with opioid use disorder, and they've demonstrated like tremendous success. We know from the literature that both of these medications are really the only medications for opioid use disorder that have been associated with reduced overdose risk, and namely reducing that risk by over half, which is very significant. However, despite this efficacy, medications for opioid use disorder continue to remain vastly underutilized. And in general, we've seen just amongst substance use disorder treatment programs, utilization in general, just for SUD services, has also sort of decreased. So that's sort of in the context of some of these next policy updates we're going to talk about. So next slide, please. Great. So we know that in terms of like the federal government, they've put out various like opioid treatment guideline updates. Particularly this one is from SAMHSA, which went into effect last month, excuse me, and will become or is expected to be fully implemented in the next like several months or so. And just so some really big picture, like high level sort of bullets of what these like updates entail. In terms of just like terminology, they've updated the terminology to everything from medications for treatment of opioid use disorder and other changes in terms to move away from sometimes more stigmatizing terms or those that are not as compassionate. And that these changes align with just current medical standards and again, emphasizes compassion. In terms of like the next bucket of changes with respect to oversight, there have been changes in accreditation standards that are more strict. There has also been an expansion of roles or scope, in particular scopes of practice for nurse practitioners and physician's assistants who in opioid treatment program settings will now be able to prescribe, dispense, and manage treatments, pharmaceutical treatments, including methadone in those settings. And of course, there will be some variance for a lot of these like sort of federal updates based on state laws. And so the purpose of this is really to expand access to care, particularly in areas that have been underserved. And even within our large city of New York, which is not necessarily underserved by opioid treatment programs, but we have, particularly since the pandemic, seen various fluctuations in like staffing and staffing turnover. So being able to expand the roles that can prescribe is a good thing. Next slide. Great. So the next area concerns like just sort of easier access to treatment. So some of you may be familiar with when it comes to admissions, particularly in opioid treatment programs, there had historically been a requirement for a 1-year history of opioid use, and that has in order to start methadone treatment, and that has been removed. And instead, things are being a lot more like streamlined with respect to providing treatment to a lot of different individuals. Additionally, like electronic consent for treatment is now permitted, which enhances flexibility and reduces barriers. In terms of take-home doses, the great news is that a lot of flexibilities that began to come online like during COVID-19 have now become permanent with respect to methadone and take-home doses and reflects a greater shift towards trust and patient responsibility. And this also entailed being able to change like the limits in terms of treatment duration with respect to take-home doses. So for example, in the initial like 2 weeks of care, programs are allowed up to 7 days worth of like take-home doses. Then after those initial 2 weeks, then 2 weeks of take-home doses are allowed. And then following that first month or so of care, take-home doses can go as much as up to 28 days. And then in terms of telehealth, we know that telehealth was a great boon, particularly during the pandemic. And it's been able to expand access and allowing those to be screened more readily for buprenorphine initiation by audio or audio-visual means, and with respect to methadone in terms of audio-visual telehealth. Next slide. In terms of better patient care, treatment plans, a lot of what was stressed in these guidelines is the importance of individualized treatment plans, created through collaborative decision making, right, between patients or program participants and their clinical team in order to emphasize reducing harm. And there were also some measures put into place with respect to interim treatment. Again, being able to help folks allow them access to care within the first 180 days. This again may apply a little bit more to those areas, maybe outside of New York City, but even within the state, where they may be limited access or waiting lists for access to things like methadone and other medications for opioid use disorder. Next slide. Great. And then last but not least, also just wanted to highlight a recent DEA rule change, or near recent. It was back in 2023 or several months ago. The DEA implemented a significant update to the regulations governing the dispensing of narcotic substances for opioid use disorder, narcotic treatments for opioid use disorder. And this was to improve access to care under the guidance of the Easy Medication Access and Treatment for Opioid Addiction Act. And basically, it allows healthcare practitioners to dispense up to 3 days supply of narcotic drugs at one time, which can be used to initiate either maintenance or detoxification, or both types of treatments. And basically, the impact of this regulation is it helps minimize the need for frequent patient visits during that initial phase of treatment, and simplifying the process and reducing logistical challenges like transportation, for example, by just being able to give them 3 days at once. This hopefully does decrease administrative burdens and streamlines the initiation of treatment, for example, in settings like, let's say, an emergency room or other places where folks may go to or may be in need of care. And yes, and that overall, this rule change represents a proactive approach to addressing barriers in opioid use disorder treatment and promoting greater access to medications and improving overall care and treatment effectiveness. So next slide. I believe we might be moving along into, as Shivani flagged, sort of the meat of our today, which isn't about us presenting. You could go to the next slide, Winnie, and that is just to kind of talk a bit more, have kind of more of a robust discussion about given these various kind of policy changes that have occurred at the federal level, and we didn't get into the specifics of state, but a lot of these federal changes will have to be enacted at the state level, whether it's by regulatory agencies like OASIS, or I believe as of this morning, I think we heard that bills are in process in the House chambers with respect to enacting what's needed for that 3-day rule by the DEA I just mentioned. But overall, just want to take a step back, that given these kind of pretty sweeping and significant changes that have occurred with respect to access for medications for opioid use disorder, as well as overall, in terms of care, just wanted to kind of open things up and kind of get a sense from you all as to from these, is there anything in particular folks are either excited about or concerned about in terms of not just the announcements about the potential of these changes, but what the implementation of these may look like, as well as like what we see as possible like opportunities that can come from these like policy shifts in terms of improving access, engagement, as well as very importantly, the quality of care for those who use substances, and of course, the opposite, or if people see that there's gaps or things that are still missing and that aren't really being addressed by these different policy changes. So I will stop talking because I did a lot of talking, but very eager to just sort of open it up and see if folks have any like kind of thoughts or reactions that they want to share about.
Alicia, go for it.
Thank you. Hi, everybody. I think there's a lot to be excited about, and I do have a couple of questions, specifically about expanding the take-home dose. And so I think what I